welcome. Oh. Welcome to our final MedEd Grand Rounds for the season. I have with us Dr. Thea James. She's the Vice President of Mission and the Associate Chief Medical Officer at Boston Medical Center, Boston University School of Medicine. She is an Associate Professor of Emergency Medicine and Director of the Violence Intervention Advocacy Program at Boston Medical Center. Dr. James is a founding member of the National Network of Hospital-Based Violence Intervention Advocacy Programs. In 2011, she was appointed to the Attorney General Eric Holder's National Task Force on Children Exposed to Violence. Dr. James completed her undergraduate medical degree at Georgetown University School of Medicine. She then completed her residency training in emergency medicine at Boston City Hospital. As Vice President of Mission at Boston Medical Center, Dr. James has primary responsibility for coordinating and maximizing the medical center's relationships and strategic alliances with a wide range of local, state, and national organizations, including community agencies, housing advocates, and others that partner with Boston Medical Center to meet the full spectrum of patient needs. Through her efforts, innovative and effective new models of care that are essential for patients and communities to thrive have developed. Specifically, integration of upstream interventions into Boston Medical Center's clinical care models have been critical to achieve equity and health in the broadest sense. Dr. James has been widely recognized for her work as evidenced by the numerous awards she has received. I'm just going to list a few. She was the 2008 awardee of the Boston Public Health Commission's Mulligan Award for Public Service, and the recipient of the Suffolk County District Attorney's Role Model Award. She also received the Boston Business Journal Healthcare Hero Award 2 times in 2012 and 2015, and she was also the recipient of the Schwartz Center Compassionate Care Award. Her passion is also in public health, both domestically and globally. She is a supervising medical officer on the Boston Disaster Medical Assistance Team. She has been deployed to multiple places, including post 9/11 in New York City, Hurricane Katrina, areas affected by Hurricane Katrina in New Orleans in 2005, to Iran in 2003 when they had their earthquake, and in Haiti in 2010 after the earthquake. So today we have the pleasure of Dr. James coming to speak about her work. The title of her talk is Shifting the Healthcare Paradigm, Leveraging Root Cause to Disrupt Barriers to Thriving. Please join me in welcoming Dr. James.
Thank you so much. Good morning, everyone. I want to start off by saying I'm really honored to be here this morning, and I am deeply grateful for having been invited to share this time with you this morning. You know, I'm an emergency medicine physician, as Rose said, and emergency medicine provides you with a unique glimpse into human nature, the human condition, and all of what constitutes life. And it's taught me everything I know about what my patients say they need to be well and to stay well. And, you know, one of the main messages and lessons I've learned from this is that, you know, medicine is always changing. Treatment regimens for medicine, these things are always changing. But the one thing that never changes is that as human beings, when we have to make hard decisions, particularly when we have limited resources, and we have to make hard decisions between taking care of your family, feeding your family, paying for stable or unstable shelter, keeping the lights on, the heat on, when you have limited resources and you have to make hard choices between those things, and using those resources for a copay to get for a doctor's appointment, or buying a prescription, or paying for transportation to get to a doctor's appointment. Healthcare health and healthcare will always rank secondary to surviving, let alone thriving, just even surviving. And so it's not exactly, I mean, it's been a long time since I was in medical school, but I don't recall them ever teaching us about the intersectionality of those things and how those things all work and how we should approach our craft when we are dealing with human beings. So there's a national conversation going on right now about these things and determinants of health and that type of thing. Everybody's talking about it. And what I want to do today is to maybe start off by talking about the imperative for that conversation, talk a little bit about how that is manifesting in Massachusetts, and then looking ahead to how we approach this issue that we are now facing. And so I think many of you probably know that the United States spends more money in healthcare than any country in the world. But when you look at the return on that investment, it's not so great, because when you look at healthcare outcomes, we're like here, like one up from the bottom when you compare us to the wealthiest countries in the world. And that's a problem. And this is the way it looks in Massachusetts. Over the past decade, this is Medicaid spend. This is the trajectory of Medicaid spend over the past decade in Massachusetts. And as you can see, it's going up and up and up and up. And so in Massachusetts, we call it MassHealth. Just a few years ago, MassHealth said, you know, we can no longer continue to do this because healthcare costs continue to rise, healthcare outcomes continue to not rise. You know, the healthcare outcomes are poorer, and we are going to try to figure out a way to address this. So what they chose to do was to change the reimbursement model. We previously were in a fee-for-service payment model, which, you know, meant that if a person is admitted to the hospital 20 times a year, and that's, you know, it can be many more times than that, but if a person is admitted to the hospital for the exact same thing 20 times a year, people are not necessarily incentivized to understand, or maybe even trained to try to understand first and foremost what's driving that. We are more likely and more often taught to address what's sitting in front of us. We're taught about disease. We're taught about how to manage disease. And so we will like treat that disease, you know, every time that person comes in the hospital. And then without understanding what's driving it, we're discharging them. You know, you can stabilize them, but you discharge them and you send them right back to what's causing it. And it just, the cycle keeps going. So MassHealth said, you know, we're no longer going to do fee-for-service. So as of March 1st, 2018, last year, we switched to what we call an accountable care model of reimbursement, which means you get a certain amount of money per patient per month. And if that person is coming in 20 times a year, it's just like if you have a budget and you're home and somebody exceeds, you know, you have enough money to buy, I don't know, let's say $100 worth of groceries a week, and somebody eats all the groceries up in the first 2 days, it's a problem. And so, you know, we're now been compelled to try to understand the root causes of what keeps people unstable, perpetually unstable. And so as of March 1st last year, you know, we've been on that journey. But MassHealth said something very specific. They didn't just say we're going to change the reimbursement model. They said, you know, we want you to improve healthcare outcomes, and we want you to improve and decrease costs, and very specifically, prescriptively, we want you to achieve that by focusing on the social determinants of health. And so they are giving us some infrastructure, you know, hospitals in Massachusetts for their Medicaid patients. They're giving us some financial support to create an infrastructure to achieve this. And so this is what an accountable care model sort of looks like. Everybody's accountable for the patients, and we're sort of working together. So I put this slide in here because for two reasons. Number one, the other imperative for us to address these things is because some people say, well, is that our role? Well, it is our role unless we want to take all that we've learned and spent so many years learning and, have it be completely ineffective. These things are absolutely connected to health. These things are absolutely determinants of health. And so I put this slide up here to talk about how the level of education that people attain is directly related to their health. And the second reason I put this up here is that you can almost put any label at the top of the slide, quite frankly. I mean, think about it. How many times have you seen a slide or data, and no matter what is at the top demographically, it falls out like this? It just always does. And we have to wonder what that's all about. And I would say that until you understand how these things happen, we can't have the greatest opportunity to have the greatest impact on the people who are affected by this. And this is very similar, but this looks at income and health. The less money you make, the worse off your health is. And if your health is poor, for sure, the health of your children is going to be poor because they're depending upon whatever resources you have. And then even life expectancy is affected by your education. The lower your education, the shorter your lifespan is. And Dr. Sandro Galea, who's the dean of the School of Public Health at Boston University, did this study a few years ago looking at T-stops. And very similar to the slides I just showed. T-stops are like train stops around Boston. It's our sort of a transportation system. These distances are very short. None of these things are more than like 4.6 or 5 miles apart. And looking at things like families below the poverty line, for example. These are really close. And looking at premature death rates in the same places. And then looking at, again, as the previous slide set showed, looking at how education is different in these various different T-stops. And then looking at homicide rates, exact same things. Because you think about where homicide happens and the neighborhoods it happens in, neighborhoods it doesn't happen in, and you have to wonder what is the root cause of those things falling out like that. And you absolutely have to look beyond what you see in clinical settings. There's definitely, you can predict who's coming through the door with these injuries, but you also have to understand why to have effective interventions. And the thing about Boston, now this is not me saying this is what people say in Boston. They call it like a medical mecca and this type of thing. Again, that's not me saying this. This is what people say, right? And, but you have all these, world-class or great hospital systems in the same neighborhoods around the same T-stops having absolutely no impact on the communities that they live in. And so at our hospital, which by the way is a safety net hospital built in the 1860s specifically to care for the people of Boston, and I would say it's a safety net hospital, but it's fairly resource rich from the perspective of, there's a lot of creativity that goes on there. It's encouraged and supported, as a matter of fact. We have a lot of programs in Boston Medical Center that become national models and things like that. And I could not even fit all the programs in the hospital on the slide here. Some of these programs will actually alter the life course of people. And I would say probably what they do more so is fill gaps for people and keep people from falling, hence the notion or the title safety net hospital. But what I have begun to think about more and more and more, what is the role of all hospitals, all of us, safety net or any hospital? When we're dealing with vulnerable populations, is our goal or is our role charity or is it equity? Because when you think about charity, it doesn't necessarily give you an opportunity to alter the person's life course, get them on a path out of poverty, and it also doesn't break the cycle. You will always be giving something, and you will never see that person sort of step out of the line of need. You know, they will never be necessarily independent. And so I think it's really, really a question that we have to ask ourselves. And to me, the most logical thing would be to alter the life course of a person so that they can be independent and become a thriving person contributing to society. And the same would happen for their families. And so I think I already highlighted on this, you know, why should we invest in health equity? So number one, you know, it's a better business model. It's a better social model, quite frankly, because you get to give people an opportunity to be the best that they can be and achieve everything that they want to achieve in life. And, you know, people began to talk more and more about this once the CDC sort of put its stamp on it and started to say that, you know, they sort of flipped the paradigm from what we learn in medical school. When you're in medical school, when you think about what has the greatest the greatest impact and smallest impact on health, what we're taught in medical school is at the top of the pyramid, telling people to exercise, eat well, take your medication. When in fact we now understand that what's on the bottom has the greatest impact on health, because these are the things that patients, human beings, all of us, prioritize over these things at the top. I was on a panel the other day, a homelessness panel. I was actually sitting in on it for a colleague of mine, Dr. Megan Sandel, who is a housing expert, and you know, we're doing some housing work together. And the person sitting next to me were people who have been evicted and threatened with evictions and these type things. And they talked about how their health changed and how they couldn't even begin to think about doctor's appointments. And both of them they were young people, but they had chronic diseases like hypertension and diabetes. And they talked about things got so bad because they hadn't been on medications for months that, you know, it led to poor health outcomes for them. So for sure, patients are not prioritizing these things that we are taught have the greatest impact on health when other things are not in place. So when I was talking about how important it is to understand why those slides and those T-stops look like they are, and why demographically things fall out like they do, if you look at the social determinants of health and then you look back historically, I think in part a lot of those demographics started here back in the 1930s when we had these federal policies that did this thing called redlining. And redlining what they did was they drew red lines in certain communities across the country. And what this meant is that people who lived behind those red lines were not able to engage in the most common path to wealth building, which was to own a home or get a mortgage. It was a federal law. You actually could not loan to people or give mortgages to people who lived in neighborhoods behind these red lines. And decades and decades and decades and decades later, this is what it has come to, is what we see. And in many cases, some of those things, you know, are still in place, but they come in a different form. But these people have not had an opportunity to build wealth. Not only that, if you live behind those lines, you couldn't get loans to start businesses. And that is crucial when you're going to create some sort of thriving economy in communities. You think about communities you live in, and you think about what's there that makes it vibrant, you know, stores and businesses and places to eat and places to shop and, you know, places to buy, you know, housing goods and things like that. All the things you need to have a thriving community. Well, those things were not able to be built and evolved and had in these communities. And for us, these are the communities we serve in Boston at our hospital, and those communities were behind these red lines. Those are the same communities you saw with those disparate numbers and the T-stops, exact same things. And so what I would say as clinicians, when you see patients who are chronically unstable, the one thing that would be, you know, that I would say that you should maybe try to remember in your head is that all of the things, and we talk about disparities and all that stuff, those things are downstream consequences of root causes upstream. And if you can sort of just visualize walking along a stream and maybe seeing babies floating down the water or down the stream with broken arms, we can stand there and pick them out all day long, you know, for decades. But until you go upstream to the root of where those things are coming from, we'll never have an opportunity to completely sort of just eliminate what we're seeing downstream. And that's the same thing as, you know, when we continue to just treat people for things they come in with over and over and over without understanding what's causing it. And so I'm sure you've seen this slide before, you know, but when we talk about disparities, most people say equality, you know, people are without things. And so let's just give everybody the same thing. But that's also assuming that everybody needs the same thing and they're starting from the same place. So it might not be the most ideal approach. And then in the middle, it's sort of like, you know, propping people up. That's like filling gaps, a little bit like charity. And, but if you take those things away, as you can see, people will be right where they started. I think the opportunity is in the last picture there, where true equity is people having an opportunity without having structural barriers in the way to be able to achieve their highest level of life and thriving. And so at our hospital, to begin to address what I would say MassHealth sort of gave us an imperative to address, although we were already talking about it and doing a lot of programs thinking about these things. We are trying to address the things at the bottom. You know, these domains at the bottom, these are the things we're trying to address. And I would say that these are upstream interventions to address downstream problems. We are engaging with community-based organizations because as a healthcare system, you can't do these things alone. You know, you can't live within your four walls and not understand the community. And, you know, and also people outside our four walls, we're better as a team. You know, they have expertise in things we don't have. It also gives you a better reputation in your community. And we're also forging multi-sector partnerships with people we never would think of having partnerships with before. For example, you know, we work with community development corporations, we work with banks and foundations who, by the way, are coming to us and saying, we don't want to fund programs, we want to fund transformation. So they too are thinking the same way. It's like I said, there's a national conversation going on around about these things. Robert Wood Johnson, as well as JP Morgan Chase, all these organizations are funding and looking toward transformation. And we also, before we make any interventions, we're actually doing due diligence and doing analyses on various different neighborhoods, zip codes, everything. We want to do an analysis so that we have the greatest opportunity to choose something that will have impact. We want to be able to identify an area where we can have impact versus just looking at an area where we know there's an issue and just saying, we want to do this, you know, without understanding what the opportunity is. And so I will summarize that part by saying, for us to move forward, particularly when we're dealing with vulnerable populations, number one, we have to understand the context of how people got that way, understand the history. We also have to not set low bars for what we think is possible for people. Just because people are vulnerable, poor, have disparities, doesn't mean they can't achieve the same things we achieve given the opportunity. And you know, when the mayor asked us to start the violence intervention program at our hospital, for sure, I had no idea where to begin. But I did start to read some of the literature. There was not a lot of literature out at that time about hospital-based violence intervention programs, but I was reading literature, and one thing, you know, most of the time people would be talking about, if they looked at measures of success, they would measure things like reincarceration, re-injury, dropped out of school. And it struck me that these were very low bars, that people who had opportunities to alter the life course of young people who had been shot and stabbed, these were low bars. I mean, as if they could not do more. So we decided, when we started our program that we would set really high bars. And I'm talking about bars where, you know, when you meet a kid, they might be 23 years old, maybe incarcerated, is real life individual I'm thinking of, incarcerated a couple times, shot a couple times, stabbed once, and when you meet them, they're 23 years old and have a GED. And then like six and a half years later, they have a college degree and an MBA, and they're a homeowner, you know, and they have tenants and all this type of thing. Those are the type of bars I'm talking about setting to alter the life course. Doesn't matter to me what that person's prior life is. They're still a human being. And given equal opportunities and access to succeed and to thrive, they will. And the last thing is to remember not to just fill gaps, but to actually eliminate gaps. And that way you get the structural barriers out of the way. So most of, I'm just going to tell you a few other things we've done here at Boston Medical Center to try to address this transformation and paradigm shift in how our approach to caring for people. So now, all of the new interns and new fellows, when they start at the hospital, they go through this thing called hospital-wide orientation. They've always had to go through that, where you learn about the electronic medical record, like Epic, and you learn about patient quality and safety, but they also now have to go through social determinants of health orientation. It's 2 days, or it's split in 2 days. One is a didactic and the other one is a simulation. We don't want people to actually start seeing patients until they have this lens. For our highest utilizing patients, the most vulnerable patients, we have created these complex care management teams. This is part of MassHealth, and their initiative and their support. And this is a fuzzy kind of a picture, but we have probably, I think, maybe between 17 and 21 complex care management teams across our accountable care organization. Our accountable care organization is made up of Boston Medical Center, but also some other medical centers across the state. And these teams are set up in dyads and triads. So they're nurse and is essentially, we call them community wellness advocates. They're essentially community health workers, but we call them community wellness advocates because we felt like vulnerable people have always had some kind of worker in their life. You know, a case worker, a DCF worker, some kind of worker. And those things focus on deficits versus assets. And believe me, these things mean stuff to people, what they're called. And so we wanted to focus on assets. So we call them community wellness advocates. So there are dyads of nurses and community wellness advocates. And then there are triads where there's a pharmacist involved. And they all follow the patient in the community, at their homes, taking them to various different places they need for various different services they need to eliminate some of these gaps they have in their lives. And you know, when you use an approach like that to try to understand root cause and address what matters to people first and get these structural things out of the way, these are some really, really early data that show the differences in inpatient stays and the total number and the average number of inpatient stays per patient pre and post complex care management. And this is a slide of a person that was engaged by complex care management who had a bunch of diseases and was not very old. I mean, this person might be, I don't know, 48, something like that, but had a lot of complex diseases and had a lot of hospital admissions. And as you can see, once he was enrolled in complex care management, his PCP visits rose, right? Because now he's engaged in the system. But look at what happened once we helped him get housing. Look at that. And actually, this is a year ago, and he hasn't been back in the hospital since. That's May 2018, and he hasn't been back in the hospital. So it's amazing, you know, what can happen when you address these structural barriers. The other thing we're doing is screening all of our primary care patients in 12 primary care clinics, including pediatrics, and we're screening them for these various different domains like this, including behavioral health. Well, behavioral health and substance use disorder is only in 2 specific clinics, The rest of them do everything minus those two domains. And what happens is, person is screened in the waiting room, a medical assistant then takes the data and enters it into Epic. It automatically prints out a resource guide, and then when the patient gets in with the primary care doctor, it's in Epic, it's right there in front of the doctor, so the doctor can, or the provider can sort of understand what could be potential challenges to creating this or getting in the way of this treatment regimen working. And they can also understand what the challenges are for the patient and begin to engage the patient so that you can create a path forward that will have a positive outcome. We also have purchased a web-based platform so that it will be patient-facing, provider-facing, community-based organization-facing, and we can get a bunch of different data and things like that from it. It will no longer be these printouts. It will be something different that patients can have on their smartphones. So everything I've told you so far is about addressing downstream consequences with upstream interventions. Now I'm going to talk a little bit about upstream interventions. It's more of a preventive type thing, but really getting at the root cause. So about 3 years ago, the Healthcare Anchor Network was born. And born and directed by a young man named Dave Zuckerman from the Democracy Collaborative. And it started out with about 3 healthcare organizations, and now we have like over 40. I think we have about 42. But the goal of the Healthcare Anchor Network is to have healthcare systems use all of their assets to have economic impact on individuals and communities through 3, and I would say recently added a 4th pillar. And these pillars are hiring, investment, procurement or supply chain, which is local sourcing, and policy is the last one. So in hiring, it's about hiring from outside your hospital into your hospital and being very, very intentional about professional development and helping people rise through the ranks. We have actually nuanced that a little bit because we are using other multi-sector partners in employers, because not everybody wants to work in a hospital. So, you know, we have other ones that we've added, not just into our hospital, but to other employers as well. In terms of investing, I'll give you some examples of that in a second. And in terms of local sourcing, I'll tell you what we're doing for that too. But that's like getting different, you know, investing in vendors, local vendors in your community. And housing is pretty obvious, but wow, I just touched this thing and it moved. Okay. You guys are like, yeah, that's what happens when you do that. The housing thing is more about policy. We were just on Capitol Hill, the Healthcare Anchor Network was back in February, and we had 2 panels. We had a panel of legislators, HUD, people from HUD, and then we had one of healthcare systems. And then people in the Healthcare Anchor Network went and talked to their local representatives and Congress people from their states. And so in our hospital, for each one of those pillars, we have formed a work group. And so for the hiring work group, and our senior vice president of human resources has all of these people, all of these pillars are led by senior vice presidents, but they've designated people to work within those arms. And so in our hiring arm, for example, we have this program that the mayor has a program called Boston Hires. Our hospital was the first hospital to sign on with the mayor for this program, and last year we hired like 400 people through that program. We also have this program with Madison Park High School where we have kids come and spend time in the hospital with this, you know, specific goal of getting them exposed to potential opportunities for employment and education. These are some of the people we are engaging with for all of those arms, quite frankly, all of those pillars, except policy. Now, where we are with each of these organizations is different. I mean, the overall arching theme is that it's nascent. You know, we're having exploratory conversations with them. Some of them we actually have some things going on with. For example, Year Up. right under the Community Builders. Year Up is a program that helps urban kids teaches them skills, both professional skills, technical skills, gets them into internships, does mentoring, and then gets them placed with different companies. Our IT department hired 10 of them last year, all at once. We hired 10 of them. Just above it, Community Buildings is a houser. We're doing some work with them already. I'll tell you about that in a second. Hack Diversity, I just want to tell you about. We've done a little bit of engagement with them, and just want to tell you about, I'm telling you this so that you understand this whole notion of like being disruptive and just breaking structural barriers, particularly around what you think is possible. So the person who's the CEO of a company called New England Venture Capitalists started Hack Diversity, which is within New England Venture Capitalists. And so she said she started Hack Diversity because someone asked the question, and I'm paraphrasing a bit here, someone asked the question, why doesn't Google in Silicon Valley hire young people of color to work there? And somebody answered, because they only take the cream of the crop. And so she said, well, I'll tell you what, we'll make this happen here. We'll get cream of the crop, and we will, they'll come from essentially the community colleges around Boston. And so she's working with some companies, and they do something similar to Year Up, but not exactly the same. So they do mentoring for the young people. They do internships in these companies, but they also mentor the companies. So the companies will understand the young people and are able to support them in the ways that they need to be supported. And just to make a long story short, she's only been doing this, I think she's got 3 on her 3rd cohort. She was telling me that in the 1st cohort, 5 of those kids and they got hired as coders, and they are making like 6-figure jobs. I mean, coding is a high income type job, and the kids have no idea, to tell you the truth. They don't understand the opportunity as well as we would, because she was like, one kid was saying, oh yeah, I'm happy to get the job, but I was hoping like I could work for my job. I want to work for Snapchat, He doesn't even understand the opportunity. But nonetheless, that's like disrupting things and doing what people may not set bars that high to do. So, on the investment pillar, in Massachusetts, if your hospital, when you do construction on your hospital, or you add new facilities on, or you build new things, the state says that you have to give 5% of the total cost to health and the community. And the state has to approve whatever your proposal was. So for the first time, we asked as a hospital if we could invest ours in housing. And the state approved it. So again, Megan Sandel and I and our development department, we all were working on this together. And we did something like 9 projects. I won't tell you all of them. We now have 11. But one of them is we invested in a Healthy Neighborhood Equity Fund. This fund was managed by Conservation Law Foundation and Massachusetts Housing Investment Corporation. Now, you might wonder, how would your hospital back something like that? How would your board of trustees, how would your finance committee be behind something like that? So one of the things that I think may have been attractive for them is that this Healthy Neighborhood Equity Fund was squarely within our mission. So it only will fund developments that provide opportunities for affordable housing, employment, green walking space, transit, and healthy, affordable food. So it funded a development that transformed 8 units of really blight. It was an old bus depot in Roxbury. And they're building 323 new units of housing, some to own, some to rent, market, moderate, and affordable. 60% of the laborers on that job came from the community. The people in the community wanted a supermarket there. And the first supermarket deal sort of fell through. I'm not exactly sure how the second supermarket came on our radar, but that supermarket, the second one, is located in Washington, D.C. And as you know, if you're starting a business, a brand new business, or even if you're expanding it, and you go through the usual financial channels, the interest rates and things are pretty high. Well, we offered that supermarket a no-interest loan to come to Boston and build that supermarket out in the Bartlett yard where that housing is. And because it's a very community-oriented supermarket, they also teach people about the food business so that they can go on to be entrepreneurs. They do that in DC. And so we gave them a $1 million loan to come to Boston with no interest on it. And we also gave them some other funding to get started to build the store out and start hiring and that type of thing. So that's one example of healthcare anchor network from an investment perspective. And these are just some of the examples. Other things that came under that $6.5 million are housing support, where we have dyads, very similar to the complex care management teams, in housing developments. We have, we're doing an evaluation of the entire project as well. We also have a community engagement and housing stability component to this, where we did focus groups and things like that in the community to ask the communities what would housing stability look like. We're giving out some grants to people. The most interesting thing about this, though, is once we did this and got approval from the state, other healthcare systems in the city contributed to it. They wanted to join in as well. So Children's Hospital put in $1 million. The partner system, specifically Brigham and Women's, put in money, and we're working together on these things. So it just increases capacity when you have other people around you joining and doing this together. And the Social Impact Fund, again, part of that was the Healthy Neighborhood Equity Fund, and we also invested in the Boston Impact Initiative that actually funds urban startups. And so this is what Bartlett Place looks like. I mean, these apartments are absolutely beautiful. You can see the Boston skyline, and then that's just us doing a walkthrough, actually showing it to JP Morgan Chase, who's newly in town in Boston and very much into community development. They've already started doing it elsewhere, Chicago, Detroit, and places like that. And so on the procurement arm, or the the vendor arm, we're looking at our GPO. That's like, this is a big organization that all of your vendors go through, so we're sort of broadening the scope to make sure we can include people who have disabilities, who are minority groups, and women as local vendors for things we need in the hospital, and setting certain percentages and metrics about what percentage of our spend goes to those groups. And the person leading that was just telling me recently that from October 1st, 2018 until the end of January, we had increased spend by $1 million in that area. And the last thing I just want to tell you about is about investment is we belong to something that falls under the Center for Community Investment. It's called Accelerating Investments for Healthy Communities. That's where I'm flying to today. And we have these learning labs, and we're in it with these hospitals listed here. Believe me, I didn't mean to highlight Boston Medical Center there. It's just, I couldn't get rid of that blue bar. I don't know how that thing got there. It's a true story. And so, you know, the Accelerating Investments for Healthy Communities is a very rigorous learning lab. When you leave that thing, your brain is dead. Honestly, I mean, they make you work, they make you think. It's all about thinking, and basically making you think about how to be disruptive, how to change things and create things that don't exist, how to get things out of the way that are preventing you from moving forward, and coming up with things that are possible to do. And so, and what we intend to achieve is, you know, investments in more affordable housing. The funding happens by these organizations that you see. It's mainly Robert Wood Johnson, but the Accelerating Investments for Healthy Communities Learning Labs is funded by Robert Wood Johnson, but the CCI is funded by the groups you see here at the bottom. And so this is just about housing. I don't even want to spend time on it. I just want to say it's complicated. You know, accessing housing is very complicated because you're dealing with fair housing laws, you're dealing with different types of vouchers that, you know, mean that you can do different things with them. They're for different populations. And it's not about just putting people in a house. You know, you have to teach people and help people and partner and mentor people so that they can thrive. Particularly if people have things like substance use disorder or serious mental illnesses, or even chronic diseases. These people need different types of partnerships and mentoring within housing. And last, I would say, you know, everybody wants to do something good. You want to do good in the world and good for people. But I would say in doing so, you will not be doing it on your own. And your finances are going to come from somewhere. And when you're in a healthcare system, no matter what it is you're trying to do, the people who have to help you, the people in finance, are always going to be thinking about finance. They're going to be thinking about the return on investment. And the more and more I think about how we, you know, co-power and empower people in communities to be able to be independent and financially independent, I can see how and why they think about these things. So I think, you know, as a model, you know, when we create interventions, they should have social impact, business impact, and create an opportunity for a return on the investment, and not from the perspective of capital, just gaining capital, but to use that what you gain to reinvest in these models. And the last thing I'm going to say here, this is the last slide, is, and then I'm going to show you a really quick video. Again, this whole transformation of Medicare reimbursement in Massachusetts has really created a collaborative of healthcare centers that never existed before. It just didn't. And these are all accountable care organizations that are, you know, healthcare organizations in Boston who never sat at tables before. We've been sitting at this table, this HDOH collaborative, since May of 2017. And I have enjoyed it so much. I've gotten to know people, and we're, you know, we're vulnerable. We allow ourselves to be vulnerable. We learn from each other. And I just could have never imagined something like this would happen. And so I just want to show you this quick video, which I call a proof of concept about structural barriers and doing things in a way that have not been done before or that you couldn't imagine. Let me do this thing.
I got shot in the leg, the left leg, the thigh. So I didn't go into the hospital till a few days after the shooting because it was a kind of a sticky situation. Police was already showing up at my door. As soon as the swelling went down, I seen the bullet. And then that's when I went to BMC. Yeah, at first it started off with just phone calls. I don't remember exactly what it was. The sign had stuck out to me that actually made me walk in there. That time it was basically like, I ain't getting shot again. So I made a vow to myself, I ain't getting shot again.
The majority of the population that we serve are young black African-American males. When we start working with them, we start trying to figure out what led them to the point to where they ended up here in the hospital with these sorts of injuries. So, I mean, we've worked with people that have multiple layers of trauma.
The way I vibe with Dave, they look like me. Dave come from where I come from. Literally, neighborhoods I come from. Dave in college. I've always been an educated, driven individual. And I always used to be like, can I do this? Can I do that? And Dave did it. So if he can do it, I can do it. Because I worked in housekeeping basically, and I was telling my manager that I can't work in trauma. Because I know where I come from. I came from the hood. I've been there before. Basically, I seen my friend dead on the table, and I didn't know it was him. And that's when I was like, whoa, I know what this is about. Couldn't keep working there. I love video games and all, just to wonder how to make them. But coming from where I come from, we don't really have those type of opportunities. We don't even know where to begin.
Every time I checked in with Icky about what was going on in some of the classes, it's like he came to life. Well, after Icky graduated, I told him, it wasn't us doing this, this was all you doing it. And he didn't understand it at the point. He was like, no, Dave, I think you're being humble. But I think it was you. I was like, no, I couldn't have graduated. You're the one who did it and graduated. And it took him some time to realize it was him.
When I graduated, I just hoped this accomplishment pays off. Literally, it was running through my mind when I grabbed my diploma and I seen everybody, I hugged everybody. I put on a big smile. I was happy, but in the deep down inside, I was like, I hope this works.
The workforce development coordinator was just like, that's the next move. And she had a conversation with the Ransoms and with Icky, and I think it just grew on its own from there.
That really gave us an opportunity to kind of see who he was as a person, what was important to him. That was what let us know that, okay, he's somebody that would be a perfect fit for our organization.
So also his excitement.
Yeah.
Just he eats, breathes, and sleeps coding and programming and gaming. So it was hard for us not to get excited too.
We're Roxbury residents as well. Half of our young men of color have some kind of Corey background. We're using programs like this where people can learn and get exposure to things that they don't typically have the opportunity to see.
This was kind of our opportunity to meet him where he is, and he's already gotten a lot of great experience from Simbo. How can we push this up even more and help him achieve what he wants to achieve?
He's already going back and talking to other Simbo graduates, talking to other people who are in this community.
This is the plus about being an intern at Include and the fact that they're a small business and what they do is exactly what I want to do. I get to see the inner and outer workings of the business. We all make mistakes, right? All of us. Every single last one of us. Don't judge us by the mistakes we make. Judge us by what's in here, or in here.
Thank you, everybody. Thank you so much. Any questions? Anyone have any questions? Oh, yes, sir. Sorry.
I'm going to sound like I'm pouring cold water.
I'm an ER doctor, so I'm used to it.
Demonstration of what can be done. Except I'm old enough now to have seen these kind of projects. Where these projects rise and fall and run out of energy and run out of money, and we don't seem to be able to permanently get it there. Don't you get discouraged about that?
No, I don't, because that example of, for example, of what I just showed you, like with Eki, for example, that worked, you know, and so that program now is like 12 and a half years old. To be really honest with you, that program has been, that is what gave me the, I don't want to say courage, but that's what gave me the idea that we could translate that to the entire patient population by going to the root cause. And so, I mean, I wasn't born into, you know, and I wasn't born with every single opportunity that people have, but I was, you know, my parents mentored me a lot, and they basically mentored me around two things, like root cause. I mean, that's what I would look at, say now in retrospect. You know, they mentored me in root cause, humanity, like my father never allowed me to pass judgment on people and things like that, and not to set low bars, ever. Even when you don't really have, you know, what should get you there other than us telling you that, and not letting structural stuff kind of like get in your way. But I know what you're talking about, but I kind of like don't see it as a, and maybe I'm naive, but I don't see it as a program. I see it as a paradigm shift, because you're transforming not just one person at a time, but you know, we're doing deep analytics in communities to transform where those things begin, where those disparities and things begin. And so we have so many analysis and things like that going on right now in our hospital. It's really amazing. And when you sort of overlay all these data, you get to see some really, really great opportunities. And so for MassHealth, I mean, they have given us support to build a sort of infrastructure. And of course, everybody's asking around sustainability. But, you know, we hope that by addressing it from a place of root cause, that we're able to create sustainability in this way. I mean, we're all on a journey, and all on a learning journey, and I would say a nascent. We only just completed year 1 of this whole thing. But I'm very hopeful. And again, I feel like the hope is based on proof of concept, you know, what I've seen over the years.
Congratulate you for your energy and your values. Thank you.
No, thank you. Thank you so much. Yes, I'm sorry. There's like everybody going at once. Yes, I'm sorry.
Thank you, that was excellent. Wanted to ask you, though, you highlighted what the academic medical centers are doing, even nationally as a social network. You know, Boston is the epicenter of all of these universities, and at least one of them has a massive endowment. Are the universities also part of some of these partnerships?
That's a good question. That's a very, very good question. So the Healthcare Anchor Network has recently engaged universities in Boston, and I would say more to come on that. Yeah, more to come on that. But I know the Healthcare Anchor Network has recently engaged them. So we'll see what happens with that. Yes, sir.
That was a great talk. Thank you very much.
Oh, thank you.
When you look at 30,000 feet, the disparities you pointed out are totally obvious. I'm
Yes.
wondering, in your clinical experience, how do those macro things affect how we take care of people at the point of care?
Yes.
Do you see those same sort of disparities, and how do you think those two things are related?
Yeah, so 80% of our patients are government insured. And when you, I mean, by comparison, we're like the inverse of everybody else in town, except St. Cambridge Health Alliance. And so most of the approaches we've had to address those have been through that slide I showed you with the various different programs that are there. I mean, and so, but now the way we are addressing it is trying to understand it. And I don't know if I'm answering your question, but we're trying to address those disparities as we see them by getting to the root cause, starting with screening them for social determinants of health. And by the way, it's no surprise that what people are screening highest for wanting help with are things like employment and education, because it's not lost on them about why they are where they are and how they could get to a different place, by the way. Does that answer your question? Okay, sure. This lady had a question too. Yes.
Thank you so much for coming to the great talk.
No, thank you.
My question is, you talked about these 4 key areas that you're working on with patient education, housing, food, and behavioral health, and I feel like a lot of that takes political buy-in or investment buy-in. Can you talk more to how you use your voice as a physician to advocate for these investments and talking to politicians in general?
Yeah, so first of all, our governor is all in. He is all in when it comes to both behavioral health and substance use disorder, especially substance use disorder. The Graken family gave us $25 million a couple years ago, specifically for substance use disorder. We already had about 6 or 7 substance use disorder programs in the hospital for different patient populations. And so in Massachusetts, nobody's pushing back on substance use disorder, because it's like, compared to, you know, other states, it's pretty bad. And so that part hasn't really been hard. Yeah, so it hasn't been pushed back. And on federal level, like I was saying, we just started in February talking about housing on a federal level when we hosted a Housing for Health event on Capitol Hill. And so, you know, we're getting there, and there's some interest there as well. So there hasn't been a lot of pushback on it so far. Yes. Yes, ma'am.
Thank you so much for a very informational talk. How
No, thank you.
If you could share the ways in which these programs are integrated in the learning in medical school and also in the
That's a really good question. I think so. You know, I don't know what's really being taught. I have had exposure to the medical students advocacy group. You know, I gave them a very similar talk not long ago, last month. I used to do it for the first year class every year over the last, I don't know, 15 years or so, but I don't do it anymore once I started doing more administration. And so I know they're talking about social determinants of health in the medical school, but I don't know to what degree. But I have, you know, I'm very connected to the deans and the dean of the medical school and other people who are in charge of the student curriculum. And I know they're working on some things because the person who helped develop the screener, for example, is now working with the medical school on some projects as well. So I know it's there. I just don't know, you know, to what degree.